we go. Aloha, my name is Melody Aduha. I am the chair of the Health Committee, as well as co-chair of the Environmental Caucus, as well as vice chair of the Kupuna Caucus. And at this time, we'd like to welcome all of you for joining in this Lunch and Learn. It'll be a very informative Lunch and Learn, and I know a lot of you are interested. How can we reduce healthcare costs by 20%? Well, we have the answer with Dr. Kemble. Now, Dr. Kemble, he has attended medical school at the John A. Burns School of Medicine, as well as the Harvard Medical School. He is trained in internal medicine and psychiatry. He recently retired from the private practice in psychiatry, but practices part-time at Queen Emma Clinic, caring mostly for Medicaid patients. He is an assistant clinical professor in medicine and psychiatry at JABSA. He is also past president of the Hawaii Psychiatric Medical Association and the Hawaii Medical Association. Dr. Kemble has a long-standing interest in health policy and healthcare reform. He was appointed to the Hawaii Health Authority in 2011, which is charged with the overall health planning and designing of a universal healthcare system for all residents in the state of Hawaii. He is a board member of Physicians for National Health Program, a physician single-payer advocacy organization in which he has been a member since 1989. Let's all give Dr. Kemble a warm welcome. And at this time, Dr. Kemble, you have the floor. And thank you for joining us.
Thank you very much. I'm going to share screen. All right, how Hawaii could reduce healthcare costs by 20%. And as I said during the preliminary discussion, getting there from here faces a lot of obstacles, which I will discuss to some degree. If we could actually overcome them and do what I'm saying, we really could reduce costs by at least 20%. I have no financial conflicts of interest to disclose. I'm not paid for any of my healthcare reform activities. I am not a special interest. I am a retired physician and a concerned citizen who's alarmed by the direction that things are going, and that's it. What is the high cost of healthcare in the US and Hawaii? You're being told by the health insurance plans that the high cost of healthcare is due to fee-for-service causing excessive volume of care and fragmentation of care. But this is self-serving insurance industry propaganda, and it is not actually true, and I will show you the evidence for that statement. Overutilization is not the problem. Doctor visits and hospital days in the US per capita are among the lowest among industrialized countries. Inadequate access to appropriate care driving costly complications is a much bigger problem than unnecessary care due to fee-for-service. There has never been any study showing overutilization or widespread unnecessary care in primary care. Yet the primary care has been the focus of payment reform, trying to reverse the incentives of fee-for-service to correct this imaginary problem. Excessive administrative costs driving much higher prices is by far the biggest cost driver, and exorbitant drug prices are the second biggest cost driver. These are what we should be focused on if we want to bring the cost of healthcare down, not fee-for-service. Just to show you the difference in administrative costs between the US and a country that has a single payer system that doesn't use insurance companies. Hospital billing and collections are 5 times of what they are in Canada. Physicians also 5 times what they are in Canada. Overall administrative costs for the whole system are 4 times what they are in Canada. And over the past 50 years, this is a graph. The green at the bottom is the growth in the number of physicians in the US. The red is the growth of managers and administrators. And as you can see, managers and administrators have exploded while physicians have barely doubled in 50 years. And this is where the excessive cost is. Most of this is unnecessary. They don't have all those administrators in other countries. That's why their systems are much cheaper. Their relationship to healthcare, other than a few necessary administrative functions, is largely parasitic. If you look at the graph, there's a sharp spike in the late 90s, which is the introduction of managed care and pushing HMOs and capitation. There's a whole managed care wave that went through the country then. And then there was a backlash because of the incentive to skimp on care. But at the end here, which on my screen is blocked by everyone's pictures, but there's another big bump just in the last 5 years. And that is the value-based payment bump, which is the payment transformations that are recommended in the Affordable Care Act and that have been pushed by HMSA here in Hawaii that have resulted in another bump in administrative costs. Okay. So this is a brief history of privatization of public health insurance programs, which is Medicare, Medicaid, and public employee health benefits. A lot of money flows through publicly funded insurance plans. So private business interests want to tap into it. If they have a role of just processing claims and credentialing and customer service, that would be about 2% of the healthcare dollar. But if they can persuade government to allow them to take on insurance risk and manage care, that turns out to be 12 to 40% of the healthcare dollar. So of course they're pushing the second option. So they need a rationale of why they are needed in healthcare, and so they make stuff up. Government's always inefficient. Private insurance companies can manage healthcare to make it more cost effective. Fee-for-service incentivizes doctors to deliver excessive volume of largely unnecessary care, and this is a major driver of excessive costs in US healthcare. Care is fragmented into fee-for-service, and private health plans and integrated delivery systems can more effectively coordinate care, restrain unnecessary care, improve access, and reduce costs. Turning healthcare funding over to capitated private entities makes costs predictable, and competition and market forces will control costs. None of this is true, none of it. The Affordable Care Act has accelerated privatization because it was largely written by people who came over from the health insurance industry. To control costs, we must move away from fee-for-service with its volume incentives and replace it with value-based payment by shifting insurance risk onto providers of care. If you pay doctors and hospitals upfront per person with capitation and say, this is the money, you cover the care, then they have an incentive to skimp on care and to avoid taking on sick people. They argue that the Affordable Care Act says we can eliminate fragmentation and improve quality by organizing doctors and hospitals into accountable care organizations that can accept capitation and insurance risk. Or we can have large insurance plans and hospital chains paid with capitation, buy up physician practices, and integrate them. None of this actually works. But large numbers of politicians and health policy experts have drunk the Kool-Aid. So risk shifting started with the managed care era in the 1990s with capitation and HMOs, health maintenance organizations. And then in the 2000s, we started getting pay for performance or pay for outcomes and quality metrics imposed by the insurance companies. And in the 2010s, with the Affordable Care Act, we had value-based payment and accountable care organizations, which are ways of prepaying for healthcare and holding providers accountable for the cost of care. More pay for performance and quality metrics. The ACA and CMS, which is Medicare, have accelerated this trend. And in 2021, we have the effort to privatize the rest of Medicare with direct contracting entities, which is basically like stealth HMOs, which are being imposed without people's knowledge on the rest of the Medicare program. So all of these have the same false rationale that excessive US healthcare costs are due to unnecessary care caused by the presumed financial incentive under fee-for-service to maximize volume of care. And they all have the same solution, which is shift insurance risk onto doctors and hospitals, pay them up front and hold them accountable for the cost of care. But managing risk, the way you succeed if you're being paid with capitation is you try to reduce how much you spend on care, and you need to know how expensive your patients are. So this requires a whole lot of information and big data and information technology, number crunching and things like that. which doctors in independent practice can't do. So this cements a role for the insurance industry and healthcare. The problems with this are, first, the premise is false. Utilization of care in the US is low compared to other countries, and it was the lowest in the country in Hawaii when we were all paid for fee-for-service. There is no evidence that anyone has ever come up with of excessive utilization in primary care paid with fee-for-service. And when you pay doctors with capitation or risk-shifting schemes, you create perverse incentives to skimp on necessary as well as unnecessary care, because if you're paid up front, the less you spend on care, the more you get to keep. And there's also an incentive to avoid sicker, more complex and socially disadvantaged patients who would cost you more, which aggravates disparities in access to care. And risk shifting involves high administrative costs, which aggravates the real problem of excessive administration. It opens the door to widespread corporate fraud and abuse. And none of these are problems with fee-for-service, which does not involve risk shifting. And fee-for-service is much cheaper to administer. So what does the evidence say? Overutilization of care due to fee-for-service is a trivial problem. There are anecdotal reports of marginally necessary procedures in certain cities, and there is an issue with this with for-profit hospitals, especially on the mainland, which we don't have here in Hawaii. Nobody's found evidence of excessive care with primary care paid with fee-for-service. As I said before, we have among the low end, at the low end of utilization of care in the US compared to other countries, which their systems cost half per person what ours does, and they mostly use fee-for-service. And one study specifically went looking for overuse of healthcare. This is published in 2012, so it was just before the Affordable Care Act, when everyone was still paid with fee-for-service, and they found remarkably little. So fee-for-service cannot be the cause of high US health costs. The difference is high administrative costs and high pharma prices. That's what we need to focus on if we want to control costs, not fee-for-service. But corporate fraud and abuse by insurance plans, HMOs, Medicare Advantage, and Medicaid managed care plans is widespread and hugely expensive. Cherry picking and lemon dropping, that's marketing to healthy people and having policies that discourage sick people from coming into or staying in the plan. Upcoding to inflate severity of diagnoses to beat risk adjustment formulas. Deceptive marketing, denial of necessary care, narrow networks and restricted access to care, slow claims processing, high rate of denials, and meaningless quality metrics because they only measure what's easy to measure, which is less than 2% of what doctors do. So those are of questionable validity, even if they say our quality metrics are good. Easy to teach to the test. This is an example of upcoding. So in a Medicare Advantage plan, CMS, which is Medicare, pays the Medicare Advantage plan a base of $4,000 per person. If an individual has a few chronic diseases like diabetes, mild heart failure, a history of an ulcer, and a history of asthma, and these are coded generically, the risk score goes up to 1.03 and the plan gets paid $9,000 per year for that person. But if a plan can get the doctor to change the diagnosis from obesity to something more specific like morbid obesity, or diabetes to diabetes with retinopathy, or depression to major depression, single episode mild, or asthma to chronic obstructive pulmonary disease, or ulcer to ulcer stage 3, all of a sudden the risk score goes up to 3.63, and now CMS pays the plan $32,000 per year. So this has spawned a whole industry of Medicare Advantage plans and Medicaid managed care plans, sending agents to patients' homes and doctors' hospitals, combing their records, interviewing them, looking for other diagnoses that they can add or make more specific so they can make more money off risk adjustment. There have been multiple articles in business news within the last few months of whistleblower complaints against Medicare Advantage plans alleging widespread upcoding by the plans. And Department of Justice has gotten involved in almost all of these, and they are finding that the problem is industry-wide, it's of major proportions, In 2013, an audit showed that they were overbilling because of upcoding to the tune of 14.1 billion per year. And the number of people in Medicare Advantage plans has more than doubled since then. So now they're paying Medicare Advantage plans around 290 billion, of which 10% is fraudulent. So that's 30 billion a year that may be going astray. There are similar whistleblower lawsuits pending or have been settled against Medicare Advantage plans run by all these other major insurance companies. So what's happening to healthcare reform in Hawaii? Prior to the Affordable Care Act, we've had our Prepaid Healthcare Act in place since 1974. And this gives us an ERISA exemption, allowing the ERISA law is the Employee Retirement Income Security Act, something like that, which normally would ban an employer mandate, but we got an exception to allow an employer mandate, which means that a broad cross-section of the population has coverage. There are mandated comprehensive benefits, no pre-existing condition exclusions, no deductibles, only 10 to 20% copays, and we had mostly small independent practices paid with fee-for-service. With that situation, in 2008, we had the best benefits, broadest coverage, best access to care in the US. Our dominant insurer, HMSA, standardized and controlled fees. We had minimal controls on utilization. HMSA prided themselves in having the lowest administrative costs in the US among health insurance companies. And we had among the lowest commercial health insurance premiums in spite of our rich benefits and broad coverage. So we had by far the most cost-effective healthcare system in the whole country. And our Medicare costs per capita were also the lowest in the US. So why did we need healthcare transformation? So HMSA was not able to engage in risk avoidance because of their history and large market share. So they were getting stuck with all the sick people, but the other insurance plans all engage in risk avoidance. Kaiser markets to healthy people and they limit their exposure to Medicare and Medicaid. The smaller insurance companies market to small businesses, which tend to have a younger and healthier workforce than big businesses do. So HMSA said, well, if we can't do that, play that game, then what we'll do is we'll shift risk onto doctors so they have the incentive to restrict and deny care and avoid high-risk patients instead of HMSA being in that role. Value-based payment means prepaying for payment upfront and holding doctors accountable for the cost of care. And this requires the ability to analyze and manage risk, which is supposedly used to improve care, but actually gets used to avoid high-risk patients. And this means big data that only an insurance company can provide, and that's good for HMSA. It cements their role in health insurance. And it also means high administrative costs and is driving doctors out of practice or into employment by hospitals. Now, if a doctor closes their private practice and goes to work for HMSA or Hawaii Pacific Health or Kaiser, those plans can all charge a facility fee on top of fee for service. So the same doctor providing the same service costs the system more when they're employed by a hospital than when they're an independent practice. So this is helping to drive cost up. High administrative costs is not a problem for HMSA as long as they can force everyone to accept higher and higher premiums as much as they need. And administrative costs can be hidden. After the Affordable Care Act passed, the Obama administration negotiated with the health insurance industry to classify medical management as healthcare, not administration, in calculating their medical loss ratio. The medical loss ratio is an insurance term for how much of the healthcare dollar gets actually spent on healthcare, which in insurance speak is a loss. So formerly, medical management, which is things like utilization management, quality improvement, programs to try to control misutilization of care, those things were considered administrative costs, but now they're considered healthcare because the plans wanted to really increase what they were doing under the category of medical management with basically payment transformation, capitation, and risk shifting schemes. And they said they couldn't afford to do that if they were restricted by the Affordable Care Act to only 15 to 20% of medical loss rate, only 15 to 20% of the healthcare dollar going to administration. So now they can classify everything that they say has a goal of improving healthcare. They can classify it as healthcare and not as administration. And they can still come in under the 15 to 20% figure that is allowed under the Affordable Care Act, even if they're actually spending a lot more than that on administration. And it doesn't matter what the outcome of these payment reforms is. If their goal is to reduce costs and improve care, it doesn't matter if the outcome is the opposite. If those are the goals, they get to count it as healthcare. This is a study that looked at, okay, so you change the rules, you change the definition of the medical loss ratio. Let's apply the old rules to the current situation. And with great difficulty, they tried to figure out how much health plans were actually spending on medical management and calling it healthcare, and discovered that there had been no reduction in the medical loss, no change in medical loss ratio whatsoever as a result of the Affordable Care Act, and the supposed limit on administrative costs is not having any impact at all. So HMSA implemented primary care capitation with a pilot program in 2016 and expanded this to all primary care practices in Hawaii in 2017. This has the effect of dividing primary care practices into winners and losers. The winners are doctors with large, stable practices who don't take on a lot of new patients, who don't take on a lot of Medicare and Medicaid patients with complicated problems, so they can get lots of capitation payments that they don't have to work too hard for. Those practices can do well. But if you have a practice in Kalihi or Waianae or Kauai or Kona, and you have a lot of Medicaid in your practice, and you have a lot of people with chronic diseases and things like that, you end up not being able to cover your overhead based on the capitation rates that HMSA has been providing. So there are winners and losers in this, and the winners are the ones with stable practices in well-to-do neighborhoods, and the losers are those who serve disadvantaged populations. Capitation requires higher practice overhead for staffing and computerized data reporting. It's resulted in demoralization of doctors and a shrinking primary care workforce. And doctors have been, when doctors are getting squeezed financially by the bulk of their practice, which is HMSA, they start refusing patients who have lower paying plans such as Medicare and Medicaid. So Hawaii became the hardest state to find a doctor willing to accept new patients with Medicare over the last few years, according to Wallet Hub. And we've always had, ever since managed care, we've had severe problems with access to care for Medicaid. So at the end of 2017, HMSA persuaded the insurance commissioner that they needed rate increases of 9.3% for large group practices, 11.2% for small group, and 16.9% to 19.8% for individual and Obamacare plans. The first two are the bulk of their business. So let's average that out and say that there was a 10% increase in premiums after the first year of primary care capitation. Meanwhile, HMSA worked with a few nationally known health policy experts who published a study on their primary care capitation program to see what the outcome was. And they were disappointed to discover that there really wasn't any difference in the total cost of care. There was a substantial reduction in primary care visits, but that saves no money because the primary care doctors are now paid per patient in their panel rather than per visit. So if they see people 2/3 as often, they still get paid the same. There was a slight increase in referrals to urgent care and specialists. And there is very little difference in hospitalizations and no difference whatsoever in the total cost of care. This study did not mention medical management administrative costs for both HMSA and physicians, which increased substantially. So if there's no difference in the total cost of care, why did they need a 10% increase in premiums? It has to be the administrative overhead for HMSA of payment transformation and primary care capitation. And that doesn't even account for the administrative overhead to the doctor of those same reforms. AIMED Alliance is a mainland organization that did a survey of physicians wanting to know the outcomes of HMSA's payment transformation. And they did this in December 2019, just before the pandemic hit. They found that 55% reported that payment transformation caused them to restrict care. 36% said they'd referred patients to urgent care due to payment transformation. 80% felt it caused increase in administrative tasks with longer hours, more support from provider organizations, and hiring more staff, which means their overhead went up. 42% reported that it reduced their gross practice revenue. So if you have stable or reduced gross practice revenue, but your overhead went up, then your practice is not doing it so well. 80% felt payment transformation contributed to worsening physician shortage in Hawaii, and the same high percentage said they would not recommend a new doctor starting practice in Hawaii. Shifting from HMSA's payment transformation, let's look at Medicaid managed care. There are 3 federally recognized forms of Medicaid organization. There's the original unmanaged fee-for-service that Medicaid just pays doctors directly, which we had in Hawaii until 1994. Then there's contracting Medicaid to competing private managed care organizations using 1115 waivers, federal waivers. And Hawaii implemented this in 1994 for general assistance and aid for dependent children, and in 2009 for the aged, blind, disabled category, which includes everyone who's qualified for disability under Social Security rules. The goals of managed care are budgetary predictability. So the state pays the plans a fixed amount upfront instead of paying claims as they come in, not knowing exactly what their budget is until the end of the year. Control costs, improve care coordination and quality, and enable more flexible benefits, network management, and payment schemes. The third form of Medicaid is primary care case management, or managed fee-for-service, in which the state retains insurance risk, pays doctors directly, but they pay an extra payment to primary care doctors for care coordination and care management. Instead of having an insurance company manage care, they want the primary care doctors to do that, and they pay them extra for it. They use Section 1915 waivers to set up interdisciplinary community programs for high-risk patients, intensive case management, behavioral health support, things like that that enhance the system. And these waivers are much simpler and easier to get than 1115 waivers, and it's not difficult. If a state wants to have those kind of programs, they can apply for a 1915 waiver and get them without much hassle. So 11 states, as of 2017, 11 states had retained Medicaid as a fee-for-service program with a state-bearing risk. 40 states contracted at least aid for dependent children and general assistance to managed care organizations, including Hawaii. And Hawaii also added aged, blind, disabled in 2009. A few states, Oklahoma, North Carolina, and Connecticut, implemented primary care case management instead of managed care. Head-to-head comparisons, fee-for-service converting to managed care organizations always increased cost, always reduced physician participation and access to care, everywhere it was done, including Hawaii. Fee-for-service to primary care case management, which is only done in a few states, improved physician participation and morale, reduced ER and hospital cost, and led to a more cost-effective system. Oklahoma and Connecticut, Oklahoma had part of the state in primary care case management and part with managed care. After several years, they found out that primary care doctors were doing a lot better, so they fired the managed care companies and put the whole state on primary care case management. Connecticut noticed what Oklahoma did, and it took them years, but they persuaded their legislature and their governor to eliminate managed care and go to primary care case management. 6 years later, their total Medicaid costs, including administration, were 14% lower than in 2012. So Medicaid managed care is very profitable for the managed care plans. They're raking in billions off of taxpayer money. The more severely ill the patient population is, this is the dual eligibles are the ones who qualify for Social Security disability under Medicare rules, and they have both Medicare and Medicaid. Because it's a higher risk population, the plans are able to command higher capitation rates, enough to be sure that they make a profit, even though it's a higher risk population. And that actually is the most profitable category at $90 per member per month for that population, whereas it's only $7 for the children and mothers and working age adults. Managed care plans, whenever you do secret shopper surveys and have someone pose as a patient looking for a doctor and say, I have a Medicaid plan, will you take me as a new patient? They discovered that over half the doctors listed in the plan directories were not available for appointments. Either they had left the state, they weren't in practice, or they were not accepting new patients. But most of the plans networks were actually fake, ghost networks. And very cloudy accounting. It's very hard to know where the money goes once you turn the money over to managed care organizations. They can hide it by mixing their Medicare expenses with their commercial plan financials. So you don't really know how much is being spent on administration. You don't know how much is being spent on medical management. All you know is they say, we need more money next year. So even though the amount of money per year is fixed at the beginning of the year, the state is at the mercy of the plan, which can command whatever increase they want at the end of that fiscal year by saying, well, our expenses went up, you have to pay us more. And they have the state over the barrel because the state has now become dependent on them. There's widespread gaming of the medical loss ratio by hiding administration as healthcare. And it's very difficult for states to obtain information to effectively regulate plans or hold them accountable. In Hawaii, we converted Medicaid from fee-for-service to managed care organizations in '94 and 2009. So administrative hassles and costs, basically prior authorizations and formulary restrictions, made it much more difficult for doctors to treat Medicaid patients. And doctors started refusing new Medicaid patients. And we developed worsening access problems. Prior to managed care, almost all Hawaii doctors took Medicaid. Now, the only ones taking Medicaid now are working for community health centers or hospitals and go by the hospital's policy on what insurances they take. But the independent doctors, almost none of them are taking Medicaid anymore. Our costs, total per member costs, according to Kaiser Health Facts, were rising at exactly the US national average prior to onset of managed care. After managed care, they started rising 3% faster than the US average. It's very hard to compare state to state because there's a lot of variability in benefits and they keep changing them and how much they pay doctors and things like that. So I compared Hawaii to the US average, which is a better indicator for how we're doing. And our costs started rising 3% faster than the average consistently over the next 15 years. For mental illness, the most severely mentally ill are in the aged, blind, disabled category, which went to managed care in 2009. After that, more than half of psychiatrists dropped out. And actually, it's more like 90% dropped out. And our psychiatric ER and hospital costs 4 years later had shot up 30%. Nobody at DHS and MedQuest was willing to consider that this had been a mistake. They did not want to hear about it. Connecticut, as I said, they replaced managed care with primary care case management in 2012. So the last 4 years of managed care, their costs went up 45%. They eliminated managed care, took back insurance risks, self-insured Medicaid, and started paying primary care doctors extra to manage care. They contracted necessary administration to an administrative services only contractor. And this includes things like claims processing, credentialing, customer service, stuff like that, quality improvement projects. Those things that they wanted to have in their system or that were necessary, they contracted to a former managed care plan, but on a non-risk basis, say, what does it cost to do these things? And they pay them that amount, but they're not being paid per member. They're being paid the cost of running those services.
Dr. Kemble, you need to go to the next slide.
Not yet.
Oh,
Okay, so
Not yet.
In
Sorry. Yeah.
2018, 6 years later, physician acceptance of Medicaid was up, ER usage was down 25%, hospital admissions and readmissions down 6%, and per member Medicaid costs dropped 14% 6 years out. And their Medicaid total administrative costs, including the administrative services only contractor, dropped from 15 to 40% with the Medicaid managed care plans to 2.8% with PCCM. So how can healthcare costs be brought down? Let's put all this together. One, focus on reducing administrative costs. Pay independent physicians with a simplified, standardized fee-for-service fee schedule, regulated by the state. Use collective negotiation to keep the fee scale reasonable for both doctors and for the public, the tax-paying public. This would cost less than 2% of the healthcare dollar to administer. Pool hospital funds from all payers in proportion to the hospital needs of each plan's population. Pool it with a fund managed by the state and pay hospitals with global operating budgets. This eliminates cost shifting between plans. Plans can no longer say, we need more HMSA because we're not making enough money off of Medicaid. They're paid a global operating budget that includes all plans, and they have to take care of whatever comes in their doors. And it eliminates hospital billing and collections, which is 15% of a hospital budget. So that's 15 to 20% right off the top of hospital costs. Pay for capital expenditures with a separate fund allocated according to community need. So instead of Queens trying to generate a profit so they can afford to build a new wing, the state has a separate fund for things like that. And if we need a new hospital or a new MRI facility or a new dialysis facility in certain areas, maybe on Molokai, then we fund building it there. And it's allocated according to community need. Keep Kaiser as an integrated hospital physician group, paid with a global operating budget that covers both hospital operations and physician salaries. This would preserve all the good things about Kaiser, but it would eliminate closed panel membership and payment per capita and insurance functions. It would make Kaiser a purely integrated care delivery system, hospital physician integrated organization. People get confused about the difference between capitation and budgets because both are a fixed payment to cover costs over a period of time. But with capitation, it's a payment per person with an obligation to cover specified services over a specified time and the opportunity to keep unspent earnings as profit and risk of loss if more is spent than the capitated payment. This creates an incentive to restrict care and cherry pick healthy people and avoid sick people. It requires risk adjustment, which is an attempt to pay more for sicker people, but that adds administrative costs. And this is supposed to counter the incentive to cherry pick and lemon drop. But risk adjustment leads to gaming of diagnosis, upcoding, and basically a temptation to commit fraud to increase payment based on diagnosis, because that's, if you just use demographic data, risk adjustment formulas account for about 2% of the variability in cost, which is nowhere near enough to deter cherry picking and lemon dropping. If you add diagnoses, it goes up to 12%, which is still nowhere near enough to deter cherry picking and lemon dropping. But now you've got an incentive to game diagnosis with upcoding. Whereas if you pay, if you pay a hospital with an operating budget, but not per member, but a budget that's designed to cover the cost of their operations, there is no opportunity for profit or loss. This is just like the way the police or the fire department are paid. They're given a budget. If some disaster happens and their costs go up, they can ask for a supplemental appropriation. And if there's any money left over at the end of the year, it gets rolled over in the next year's operations. So there's no opportunity for profit in this. That's the difference between a budget and capitation. We need price controls for pharma. We need a national bill to allow Medicare to negotiate drug prices. We need to eliminate managed care plans in Medicaid and rejoin the interstate consortium that we used to be in to negotiate drug prices collectively, which worked pretty well, instead of having managed care plans negotiate prices through another middleman, pharmacy benefit managers. and we need to eliminate pharmacy benefit managers. Every middleman takes a cut and they game the system. We need to eliminate fiscal intermediaries for state-controlled, state-funded health benefits so that the state pays providers of care directly instead of paying an intermediary, a risk-bearing intermediary to say, here's the money, you cover the cost of care. You're always going to lose money when you do that. So the state needs to retain insurance risk. That means there's going to be some ups and downs of costs year to year. You're not going to know exactly what your budget is till the end of the year, but you're not going to be paying a premium to avoid that inconvenience. And if you have a reserve fund to cover those ups and downs, it's not even an inconvenience anymore. And the more people are included in the risk pool, the less the variability is proportionally and the easier it is to manage. So you want as much risk pooling as possible. For necessary administration, use administrative services only contractors on a non-risk basis for claims processing, credentialing, administrative support, for care coordination programs, quality improvement, customer service, and then fund community-based care coordination programs on a non-risk basis with global budgets. So this would include services for high-risk special needs patients, frequent flyers in the emergency room, complicated patients who would be in the hospital if they didn't get extra help being managed at home. The collaborative care model for psychiatric consultation is you have a psychiatrist and social worker care managers consulting to primary care practices to enable the primary care doctor to manage psychiatric problems themselves with backup and advice from a psychiatrist and care manager. And this is a very cost-effective model. It greatly expands how many patients a psychiatrist can cover. And this could be used for many other specialty consultations as well. Anything that doesn't require an urgent procedure. Quality improvement should be based on the professional motivation to improve patient care, not pay for performance, because that's basically administrative waste. And let's follow the example of Connecticut Medicaid, which did all these things and brought costs down. So the Hawaii Health Authority was passed into law in 2009 over Governor Lingel's veto, and it's supposed to be responsible for overall health planning for the state and responsible for determining future capacity needs for health providers, facilities, equipment, and support services, and develop a comprehensive health system that covers everybody. The vision is a universal system covering everyone. Single payer would be the most cost effective, but that's a difficult lift because we already have embedded multiple payers. But all payer is a compromise, allowing multiple payers, but requiring them all offer the same delivery system. So everyone has the same benefits, same provider network. Providers are paid the same regardless of the source of funding for any individual patient. So it's the same delivery system, even if there's different funding systems. This allows health plans to exist, but it strips them of the competitive insurance business model, and it achieves 90% of the cost advantages of single payer. Now, this health plans can exist, but are stripped of their business model is the rub. This is the issue. This is the reason why the Hawaii Health Authority is being fought tooth and nail by the insurance plans. Why, if you talk to insurance plans about the things I'm talking about, they'll say, don't listen to Kemble, he's wrong, he's been discredited. The reason is because if anyone were in policy, if legislators were to listen to my advice and start implementing some of these things, it would really interfere with their business model. But that's where the problem is. That's where the money is. That's where the waste is. And if we allow the insurance plans to sell a false narrative of fee-for-service is the problem, and you need us to manage care, to rein in abuse by all these greedy doctors, if you allow them to sell you that narrative, they will take you down the primrose path as long as they possibly can, because it's very lucrative for them. And if we were to start interfering with that, we have to take on the insurance business model. Insurance plans are needed to do claims processing and necessary administration, but they should be doing that on an administrative services only basis, not as full risk insurance plans with the insurance business model, because of all its high costs and perverse incentives. If we really did all these things, we could bring healthcare costs down by 20%. So we won't get cost-effective healthcare from health plans whose business model rewards denial of care, avoiding covering or paying for the sick, and unnecessary micromanagement of care. An all-payer system, a single payer would be ideal, probably need to happen nationally, but an all-payer system at the state level could enable universal coverage, remove barriers to care in the most cost-effective settings, keep administrative costs simple and low, eliminate micromanagement of doctors by insurance companies, and stop driving them out of practice. That's it. Questions? You can write down my contact information if you like before we go back to looking at everybody's video.
All right, does anyone have any questions for Dr. Kemble? You can raise your hand. Any questions? Mark Anthony Alexander.
Hi, Dr. Kemble, thank you very much for your presentation. I'm curious about health outcomes in Connecticut's model. Do you have any data on that?
Well, if their ER visits went down 25% and hospitalizations went down 6% and physician participation went up 30%, including among specialists who did not get a pay raise, they were still being paid 57% of Medicare, but they were willing to participate for their colleagues in primary care when they weren't willing to participate for managed care plans. All of that adds up to the cost effectiveness of care and the quality of care definitely went up.
Okay, I see two hands raised, Charlie Ice and Bill South. Charlie, why don't we take you first?
Okay, thanks. Somewhere along the line, Steve, you also outlined the actual numbers, the dollars that we would be saving by the state. And I'm just wondering if you want to inject that again at this point to indicate that there's a hidden pot of money there that's being sucked up by the insurance companies that the legislators might be intrigued to use some other way. I think we're going to have a lot more costs coming up.
Yeah, our back of the envelope calculation was about $850 million per year if we were to deprivatize both Medicaid and EUTF employee health benefits and follow the Connecticut model for both.
Okay, Bill South.
Yeah, hi. I'm not sure who the right destination for this question would be, either Dr. Kemble or you, Melody. What do we know as far as our attempts to bring these issues in the form of a bill before the legislature this coming year?
Okay, well, we are working on 4 and possibly 5 pieces of legislation, right? The resolution supporting Medicare for all, a resolution for the state auditor to do an audit on EUTF as well as Medicaid, because we need to determine, as Dr. Kemble has indicated, what is in fact being paid for healthcare and what is in fact being paid for administrative costs. And after listening to Dr. Kemble, you can see that the lines are blur, and that's a problem. And it's okay that it's blurred, and we've got to determine where the line is. Therefore, we can then go to the ledge to change the way things are currently. And then our 4th bill would be on global budgets. Now, I did want Dr. Kemble to talk about that a little bit more. Now I see, however, he's also indicating about paying independent physicians based on a fee-for-service schedule. So Dr. Kemble, perhaps our bill should then include both aspects instead of just global budgets, or shall we keep it separate, which would be 2 different bills?
Well, global budgets are appropriate for hospitals and any institutional provider of care, and that would include a community health center, a dialysis facility, a nursing home, and also community-based programs for specialized services and consultations and things like that. Those should all be given a budget, pay their employees with salaries, and let them do their thing. Whereas independent doctors, you can't pay them with a salary because they don't have an employer. And trying to pay them with capitation has all these perverse incentives. So fee-for-service is cheaper to administer and less prone to abuse than value-based payment is, and we should go back to fee for service. It worked well in Hawaii when we used it before, up until the Affordable Care Act.
So should we try to get the legislature thinking along those lines?
It would be good, and we do need to be clear that we're talking about global budgeting for hospitals only
Okay.
and nursing homes.
Okay, so that'd be two separate bills then.
Yeah.
Okay, all right. I did like what you said about capital expenditure to be in a separate fund. Because I do see when Queens needs to have an additional wing or something of that nature, they need to come and get, of course, more funding. But if that fund's already available, then that would make it easier for them to expand. Then I had a question. I'm sorry, Bill, I hope that answered your question.
Yes, it does. Thank you.
Okay, and then we can also talk about that more. Dr. Kemble, you talked about keep Kaiser as an integrated hospital physician group. Why are you, I guess, pinpointing Kaiser in this situation?
Kaiser has a fairly large market share, and they're also, this same issue has come up in California and Oregon and Washington and other places where Kaiser has a big presence. A lot of people are happy with the care they get at Kaiser. The problems with Kaiser are with their insurance functions. They cherry pick and lemon drop. They upcode their Medicare Advantage patients. They play games on the administrative side, but the doctors generally just take care of the patients. They're paid with salaries. Their payment system has been contaminated with value-based payment to some degree, but not as much as in the private sector. So you could easily fund Kaiser the way it was originally conceived to be is, okay, we're going to pay for the hospital and the doctors together. The doctors will be paid salaries out of that, and then we'll just take care of you. So that model is fine for a single payer, all payer system. I think it could work very well in Hawaii. It would keep a lot of people happy, but it would strip Kaiser of their insurance functions, and Kaiser corporate won't be happy.
Okay, thank you very much.
I've talked to multiple Kaiser doctors, and they all say, oh, I'd be fine with that.
Oh, perfect then.
It's only Kaiser corporate that would have a problem with it.
Okay. All right. Oh, Tom Brandt, you have your hand up.
Yeah, I'm not feeling the best, so bear with me. As usual. As the members of the health committee know, I'm not going to rehash everything, but in a nutshell, Dr. Kemble, after we got our meeting with EUTF and Medicaid in Hawaii remains intransigent, what's it going to take to tip the balance? What leverage do we have to try to change the conversation now after everything we've tried?
I think it's repetition, because I didn't expect we would get anywhere on the first pass. We did get EUTF's attention. They had me talk to a few board members first, and then their whole board. HMSA sent their CEO, Mark Mugiishi, to rebut me, and he didn't actually rebut anything I said. He just said, we really value your business, and we hope you don't do what Dr. Kemble is saying, because you're really important to us and we love you. And that was all he had to say about it. But he had no answer for, well, how come your premiums keep going up? How come doctors are being driven out of practice by value-based payment? How come these things are not working the way you said they would? No one's willing to ask those questions. They just sort of accept, oh yeah, premiums always go up. I guess that's the way it is. But there's a reason.
So what do we do? I mean, I listened to that meeting, and you're right. I mean, he just said what he wanted to say without engaging you directly. And the UTF board, well, they'll say, well, you guys got your meeting, so what do you want now?
Well, I think there are probably some people on the board who are intrigued, and other people on the board who just don't want to hear about anything. I think we need repetition. We need to talk to them again after a while.
Okay, thank you.
Okay, we have Scott Foster. He has his hand up. Please unmute. Oh, you need to unmute. Scott, you need to unmute.
Can you hear me now?
Yes.
Yeah.
Okay, sorry. Where is the nurses union in this?
We met with the leadership of the nurses union and they were basically supportive.
Oops.
The California nurses are very strong advocates for what I'm talking about. They're really pushing single payer at both state and national level. And
Well,
our nurse association was quite receptive.
I managed the Hawaii Nurses Union negotiations for, oh God, I don't know, 5-7 years. So I'm very familiar, or more familiar than a lot, with the issue. I've walked the lines. I've heard what the nurses say. When the nurses had their big falling out with the professionals and the RNs some years ago, you may know something about that. The administration managed to separate the unions from their management. And so when that happened, things kind of went to hell. What could they do now to get this back on the boards with you all?
That's a good question. I think there is a problem because very few people really understand what I'm saying. Because what I'm saying would keep doctors, hospitals, nurses, other health professionals, it would keep them whole. It would save money by cutting administrative overhead, not by cutting their pay or their jobs or anything like that. But they're being given lots of misinformation, including public op-eds by EUTF board, HMSA, things like that, saying that these things would result in rationing of care, cutting your pay, things like that, none of which is true. But you have to counter all the misinformation in order to get the rank and file to understand. When you explain it this way and they understand that they're going to be kept whole, they're all on board.
If I may offer a suggestion.
Yeah.
Now I'm 76 years old. I'm recovering from a stroke, have been for a couple of years. So I'm just kind of getting back in the game. I did talk to a group of nurses last week, just to kind of touch base with them. And the ones I talked to seem willing to do anything, but they need some leadership. And that can only come out of the nurses union. I don't know if Dr. Kemble, if you know any of those leadership nurses very well at the union. Now that's where you need to go, is to the union.
We met with the I forget his name, but he's the current head of the Hawaii Nurses Union, and he was receptive. But there's been no follow-up that I know of. Well, this is over a year ago.
Well, of course, the world's changed, certainly in the last 2 years since the pandemic. My suggestion is go back to the union and just sit down with them and in plain terms, explain this as best you can.
Yeah.
That's my only suggestion. I know.
That's a good suggestion.
Say what?
That's a good suggestion, and I think we should follow through on it.
Okay, well that's my advice, and in the meantime, I'll see what I can find out from the nurse friends that I still know about in the union leadership, and there's a couple of them there. Unfortunately, they're all stressed out like everybody else, only
Right.
more so because of what they've been dealing with. But that's my suggestion. Don't waste your time on anything else.
Okay.
And include the Democratic Party on this. The party can be very useful, like this meeting we're at today. Now, from what I understand, the the organization that we're talking to, Melody, the organization we're talking to today is a committee. They're not part of the of leadership, are they?
Well, the invitation went out to a lot of members as well as legislators.
Yeah. Okay. Well, I won't be redundant, but that's what I'm thinking. Go back to the union and
That's Daniel Ross.
Daniel Ross, that's who we met with, yes.
yeah, I don't know him. He's new since again, I've been out of the game for 6 years. And I'm
It may have
just
changed again. I'll check it.
okay. I'll shut up then. Thank you so much.
Thank you. Okay, any other questions? We're coming to the 1 o'clock hour. We're already actually past it at 1:04. So I'm going to have a last call for questions or comments. Okay, then hearing none, we sincerely want to thank Dr. Kemble for another wonderful informational lunch and learn. I think such an
Thank you.
overload of information every time you do this. However, we learn so much every time we review it. So we thank you again and again and again. And Scott, good comments. And Charlie, talk to the nurses union and let's just move on. And there was also a comment in the chat. This is solvable. This is doable. So full systems ahead. Okay, we've been working on this for the last, 4 years, Dr. Kemble?
Yep,
Thereabouts, yeah. So let's keep on
5, yeah.
going. Keep on going. Okay, thank you
Okay.
very much, everyone. And we'll see you next time. Dr. Kemble will be here again on December 8th. And he will be talking about our legislative priorities. So Bill, make sure you're there. And there you go. And in the meantime, we will be working on the bills and resolutions. So keep in contact with us. Keep in contact with Dr. Kemble, myself, and the rest of those on the executive committee of the Health Committee, Environmental Caucus, and Kapuna Caucus. All right. Thank you. Mahalo. All is well. Take care.
Aloha.
Get your vaccine.
Aloha, everyone. Thank you.
Safe. Wear your mask. Okay. Aloha.